automatically be assigned to a trained peer coach. The peer coach will meet with the patient at baseline and every 12 months to complete validated surveys and other screeners. The peer coach meets with Dr. Shu weekly, who reviews the patient's scores and other assessments and creates a treatment plan, including recommendations for management, which he will then share with the HIV provider and nurse, their EPIC. Now, the goal of these recommendations is for the HIV care provider to consider implementing the recommendations. The peer coaches will continue to meet with the patients weekly to monthly, as indicated and directed by Dr. Shu, to support the patient to engage both in their HIV care and support for mental health and substance use recovery. That really is the intervention, and the goal really is to support both the patients in our clinic and providers to better provide substance use and mental health care, which we know negatively impacts HIV outcomes. I'm happy to answer any questions. These are two members of the study team who you may see in clinic, and we're excited to have this opportunity to work with you to improve care for our patients at Bartlett who have these conditions. Thank you very much for the opportunity.
Thanks so much, Dr. Filati. So anyone who has questions about the PROSPER program can direct them to Dr. Filati or to these new research staff who will be in the clinic. And hopefully that'll be a big benefit to people coming to the clinic. So today, now I'd like to introduce our invited speaker for today. So we have Dr. Carrie Althoff, who comes to us from across the street at the Bloomberg School of Public Health. And Dr. Althoff, you can go ahead and start sharing. So she is an incredibly prolific researcher who has contributed much to the understanding of the HIV epidemic in the United States and globally, and has also worked with the NA Accord, with the but also with the All of Us cohort that Kelly Gibo was working with, and more recently has pivoted to try to help answer some really important questions about SARS-CoV-2 in particular in people living with HIV. And so we're really fortunate to have her here today to talk to us about COVID vaccination in people living with HIV and tell us a little bit about what we should be doing for our patients. And I think I'm not, oh yeah, and Sean, if you could stop sharing your screen so that.
Yeah, for some reason, I'm trying to figure out how to stop. Is there a way for you to kick me out? I've been trying to figure it out.
Let me see if I can make you stop. That's a good question. Probably should be. Okay, so I just made it only me. Now I'm making it everyone again. So there, does that work now, Carrie?
Yep, I got it.
Awesome. And I think, Dr. Althoff, I'm not sure that you're going to get to this in your talk, but I think the question that's been coming up for me a lot in clinic has been the fourth dose. So any insights you have into that, I'm sure all of us would love to hear as well. But thank you so much. Welcome. And we're really excited to hear from you.
Sure. Thanks for having me and for the invitation. So I'll just give this spoiler alert. I think a fourth dose is a real good idea for anyone with the CD4 count below 350 in particular. And I will definitely show some data to that extent. So first, I just want to acknowledge that I come to you today, standing on the shoulders of really incredible people across the country, namely in these 5 different cohorts that are longtime NA Accord collaborators. In May of 2020, we got together and started saying, what can we do with this data? And we took a year just pushing on our data pipelines to try and figure out where all the leaks were, how they were getting connected or not to state level vaccine registries, to testing information. For KP Mass, we were looking at CRISP and how it was connecting there, because of course their patients are seen in Virginia, DC, and Maryland. So we spent a lot of time doing preliminary work, and then we were able to pull together individual level data that these cohorts were able to quickly extract from their EHR and send to us, where we had protocols lined up and ready to go, and we looked at the data and analyzed as quickly as possible. So really, on all of their hard work is why I'm here before you today. Here are my 2 disclosures. I do have some consulting for SARS-CoV-2 outside of the work that you'll see today. And then the acknowledgements to the NA Accord, because this is how we know all these investigators and how we identified them and pulled them together. They are both individuals from integrated healthcare systems, such as the Kaiser Permanente, Mid-Atlantic, as well as the Northern California groups, as well as the Veterans Aging Cohort Study, but also from other university-based academic medical centers like University of North Carolina, Chapel Hill, and Vanderbilt. So breakthroughs post-vaccination COVID-19 illness do occur in people with HIV, but there is very little data about this. And I think that's because, you have to find the populations of people with HIV and then find this rare event of breakthrough within these groups. And there have been 3 studies highlighted here. N3C is the largest one, and that one was conducted here. Lead author was Jing Sun, who works a lot with Greg Kirk, and looking in the N3C, which is a collaboration of databases. They were able to identify over 500,000 people with immune dysfunction, and under 10,000 people of those individuals had HIV according to how they classified using EHR information. And they did see an adjusted incidence rate ratio of people with versus without HIV having slightly higher rates of breakthrough. As we all know, people with and without HIV are different on a lot of characteristics. And so in our cohort, what we tried to do is bring those differences into better alignment. Before we get too far into that, just to remind us all that right now, advanced or untreated HIV infection, which is defined as people with HIV and CD4 counts less than 200, history of an AIDS-defining illness without immune reconstitution, or clinical manifestations of symptomatic HIV, are considered in this lower group that you see here, those with moderate or severe immune suppression in CDC guidance. And as you can see here, these individuals are recommended for an extended primary series, right? So they don't stop at 2 doses of mRNA, they go for 3. They don't stop at 1 dose of J&J, they go for a second additional dose of mRNA, and then they are recommended for boosters and second boosters. So the objectives here are to estimate the rate and risk of COVID-19 breakthrough in people with and similar people without HIV in the first few months of vaccine availability. So December 11th is when Pfizer was approved all the way to December 31st, which is when our funding ended for this study. And NIAID said, okay, we've got the data. And then we went further to say, okay, it's not just about COVID illness occurring after vaccination, i.e. a breakthrough, but is that severe? And is the severity of that illness different in people with versus without HIV? So we conceptualize that as hospitalization with a breakthrough. So here are the 4 systems that we were able to nest and start digging as quickly as possible. This was a collaborative effort. We built our code book on Google Doc that was private but shared amongst our data managers at the sites, as well as the PIs and other collaborators. And we had call after call to walk through that and make sure we were getting as much information as we needed and nothing more, so we could move quickly and efficiently. And the data managers were wonderful in terms of just sharing code and processes and what they were seeing in their system versus another, so that the managers could pull this quickly. So we did have to identify individuals who are in care, and this is something I encourage you to think about when you look at all EHR studies. As we know, in the United States, our healthcare system is fragmented. Individuals seek care at numerous different places, but when you look in a healthcare system, you are making an implicit assumption that if an individual were to be vaccinated or to have an illness of COVID-19 after vaccination, that you would be able to see that in their EHR that you're looking within. And sometimes that's true and sometimes that's not. The degree to which that is true is a dial, it's not a switch. And so we did identify in care. This was easier for our integrated healthcare systems that required membership, right? So for the KPs, people enroll in those systems. And so you have their enrollment date and their disenrollment date. The VA system, we do make an assumption there, although we do recognize that many vets do receive this type of care, including medications and immunizations through the VA systems, even if they have additional health insurance coverage or seek care other places. And then we also had systems that don't have that kind of integrated care and that connection. So we did define in-care as someone who had a touch point with the healthcare system in 2019 and they were alive in 2020, and for the KPs enrolled in the health system. We identified people with HIV who were fully vaccinated according to the guidelines that stood as of June 30th, 2021, which was either 2 doses of mRNA or 1 dose of J&J, plus 14 days after the completion of those 2 types of primary vaccination series. And we looked for individuals who completed that before June 30th, 2021. Then we dove into the population of individuals without HIV, and we identified up to 3 persons without HIV and matched them to the persons with HIV based on their date fully vaccinated by plus or minus 14 days, their decade of age, their sex at birth, and their race ethnicity. Now, VAX was the only group that was not able to participate in this because the VAX study itself was matched when individuals were enrolled. So they are not matched on fully vaccinated status, but we will show you data that suggests actually they still look very, very similar. So the classification of people with HIV within these EHR systems, so it's important to note here, although this work was funded through the NA Accord, these are not NA Accord populations. These are bigger populations that include individuals without HIV, and of course they had to be vaccinated. So people with HIV, we use what we know from how we identify these individuals in NA Accord cohort studies by looking for any evidence of HIV diagnosis on or before June 30th. And then for people without HIV, they cannot have any evidence of HIV on or before June 30th, 2021. So when we go in to estimate both rate and risk, we had to define breakthrough, and this is where it gets messy. Some people get tested a lot, some people don't get tested at all. That testing behavior is really, really important. We had to establish windows. We did use the CDC guidance for when something is a new infection versus that 3-month window where it's probably the same infection being detected multiple times. We also looked at COVID diagnosis, not just PCR test results, but if that diagnosis came within the window, that 3-month window of a test result, then we did, not double count anything. So it was really the application of these windows that helped us to identify if a breakthrough occurred. We had a number of risk factors that we wanted to account for, including time-fixed demographic characteristics. Of course, their primary vaccination type was time-fixed. We did not include individuals that mixed for primary series. They had to finish their primary series. We looked at a history of COVID prior to the fully vaccinated date, which not only is of interest because of the potential hybrid immunity from the natural induced infection as well as the vaccination, but also because this is potentially an indicator for individuals who have greater exposure to SARS-CoV-2. Health system cohort, the CD4 count at the date fully vaccinated within a specified window, suppressed viral load at the date fully vaccinated within a specified window. Calendar period was critical to take into account because, as we know, there have been wild secular changes and surges of COVID over the calendar year 2021. Any additional doses that may have occurred more than 6 months after primary series, when these were occurring relative to the June 30th cutoff that we implemented for our study population, they had to be vaccinated by then. And then we looked to see as guidelines change, and man, did they change over this course. That 6-month cutoff was not really something that we chose without having the data really drive us towards that. And that data was driving us towards that cutoff because there were many people with HIV who got vaccinated pretty early when when the vaccine became available. And then of course, those negatives were matched at that time as well. And so it was about 6 months before the August 13th recommendation came out, where the CDC does recommend that people with advanced HIV or unsuppressed HIV RNA could receive this 3rd dose no less than 28 days after a 2nd dose. So a lot of our work was not just looking at our data, but also tracking all these changes over time, particularly with the changes with the recommendations for boosters. So when we set up our time to event analysis, study entry is our date fully vaccinated. That's the time point from which we are observing individuals through their EHR data. And after that time point, we also looked to ensure that we were making sure we didn't have individuals that somehow were being identified as potentially being fully vaccinated before the date that it could be possible to be fully vaccinated if they were vaccinated the very first date that these different vaccines became authorized. Study exit was the first breakthrough, which is our outcome again that is identified by PCR positivity or through a COVID diagnosis. More than 80% of our breakthroughs are identified through lab data. Death, disenrollment, or December 31st as our administrative closing date. Disenrollment is only known for KPMAS and KPNC, so we make an assumption of no loss to follow-up in our 1-year study period from fully vaccinated date to, I'm sorry, it's not September 30th, it's December 31st. And one other caveat, death, I'll talk about this at the end. Our death dates, we're also concerned that we didn't capture death, but all in all, we're talking about a year of data. And so the impact of, assuming someone's being followed for years after their death is not that here. It could only be months. And then finally, we did estimate in our analytic plan the rates in 95% confidence intervals as the number of events divided by person months, and then the cumulative incidence rates. So that probability of a breakthrough occurring, we use Cox proportional hazards models for continuous time to event to estimate that relative risk. And we looked among people with compared to without HIV to get that HIV estimate. And then we dove down deep only amongst those with HIV. What were the risk factors that resulted in a higher risk breakthrough? So we had 33,000 people with HIV that we were able to identify just within these 4 cohorts. They contributed over 22,000 person years of follow-up. 56% were vaccinated with 2 mRNAs or more than 1 J&J dose. So that's not just vaccinated, that's vaccinated plus an additional dose somewhere along the line after vaccination. 1,200 breakthroughs that we observed for a crude breakthrough rate of 55 per 1,000 person years. And our people without HIV, we had about 55,000 of those individuals. 46% had an additional dose after primary series, 2,400 breakthroughs for a crude rate of 43 per 1,000 person years. So that's the 10,000 foot view. Just wanted to show you the date fully vaccinated to the additional dose. Again, this is largely a function of when additional doses were recommended for people with HIV. And you can see that most individuals were at least 6 months out before they were receiving another dose. And then here you can see that applied my x-axis just changed here to the date of additional dose received. And, what we see is that some people were early adopters in August, but really it was surges in the fall that really drove a lot of people to receive an additional dose. So those who received an additional dose versus those who did not were older, more likely to be non-Hispanic white, fully vaccinated in March or April, and received Pfizer. Again, those are all aligned with what we know in terms of how things changed over calendar time. There was no difference by CD4 at fully vaccinated status among those with HIV who did and did not receive an additional dose. AIDS before fully vaccinated was also similar in those who did and did not receive an additional dose, as was the proportion virally suppressed. It's important to note that we have a high proportion virally suppressed in this study population. It's over 90%. And we do have a history of COVID-19 prior to fully vaccinated. That was also similar between those who did and did not receive an additional dose. So here are the characteristics at study entry, and I'm trying to get the top off so I can even see the top. So the column on the left is overall, the column in the middle is persons without HIV, the column on the right are people with HIV. And the differences that we see are with additional doses. So our persons with HIV were more likely to have additional doses, and that was largely driven by additional doses after Pfizer and Moderna because it was a smaller proportion of our population of persons with HIV who received J&J. So nothing shocking there, matching worked. We also see here that this total number of individuals who received the additional dose, here it's 44% in persons without HIV and 50% in our final study population. So this is the rate of breakthrough illness, and this is by calendar month. So you can see the waves here. You can see in December, Omicron surges. And the interesting thing is that there are times where you see a higher rate in people with HIV, but many, many months you do not see an elevated rate of breakthrough in people with HIV compared to people without HIV. The without HIV are the open circles, the with HIV are the dark colored circles. So here we see a slightly elevated incidence rate overall over all of these calendar months that are depicted here. And people with and without HIV were relatively similar, slightly higher in people with HIV at 55 per 1,000, people with HIV 55 and 1,000, people without 43 per 1,000 person years. So then when we go into the risks of the probability of a breakthrough occurring, first of all, it's important to note that this y-axis only goes up to 5%. So it is very rare that breakthroughs are occurring in persons with HIV and persons without HIV who are fully vaccinated. And in here we see that people with HIV do consistently have a slightly higher probability of that breakthrough occurring. So overall, it was about 4% cumulative incidence in people with HIV, it was 4.4%, and people without, it was 3.5% for a risk difference of almost 1%, and it was statistically significant. We did look by vaccine type. You can see overall that J&J had the most breakthroughs, followed by Pfizer and then Moderna, and consistently people with HIV did have a higher risk of breakthrough compared to those who did not have HIV. When we looked only amongst those with HIV and we looked at their CD4 counts at the time fully vaccinated, we do see that individuals with lower CD4 counts were more likely to experience a breakthrough infection. That red line at the very showing the highest probability of a breakthrough are individuals with the CD4 count less than 200. The orange line are individuals with the CD4 count between 200 and 349. The blue and the green lines almost directly overlap, and that includes individuals with HIV who have a CD4 count 350 to 499 or 500 and above. And then the purple line at the very bottom, those are people without HIV. When we look by viral load, we do see here that people with HIV, again, have this higher risk of breakthrough, but we really do not see much difference. We see a slight difference in unsuppressed individuals having a bit higher likelihood at some points along the time since fully vaccinated, but overall, we see a ton of overlap between the people with HIV, regardless of their viral suppression. Relative risk of breakthrough status by persons with HIV in our fully adjusted models suggested a 28% increase in your relative risk of breakthrough if you have HIV compared to individuals who did not. And once we excluded those with the history of COVID, again, removing this hybrid immunity, but also removing individuals who may have an increased exposure, we see the results are still the same, so that people with HIV still have a higher risk of breakthrough as compared to people without. And once we look within people with HIV, we do see a decrease in the likelihood of breakthrough with increasing age, and this is because older adults were more likely to have that second dose. We do see that Moderna and Moderna plus a third dose were really our strongest protectors. Interestingly, we also saw J&J with the second dose was very protective, although it didn't reach statistical significance because this is a small group. We do see individuals who had COVID prior to fully vaccinated were more likely to have a breakthrough infection. So we do think this is an important indicator of exposure. When we took the vax out, this effect totally goes away. So we do not see any difference in those with and without COVID. So there is something a little bit different there with the vax study. And we do see that the Delta surge during 2021 was a time of highest highest increase in the risk of breakthrough. It's important to note here too that individuals with a CD4 count greater than 500 actually really had the most protective, most protection against the breakthrough of infection. And there's a beautiful dose response that we see happening with CD4 count and no difference in breakthrough by HIV status. So we do have an infographic that we've summarized. You will see this again next week, as this paper that I just presented will be published on June 7th in JAMA Open Network. Conclusions are that breakthroughs in the first 9 months were very low. Again, it's less than 4%, and it did differ slightly by vaccine type, but again, still overall very low. People with HIV did have a higher rate of breakthrough. It's important to note that in the beginning of the Omicron surge in December of 2001, we did not see a difference by HIV status in that rate. And overall, when we look at this risk, there is a 28% increase in the risk of breakthrough in people with compared to without HIV. So we put forth and sent this to our colleagues at the CDC and said, hey guys, maybe we need to adjust this classification of who fits into your moderate and severe immunocompromised population among those with HIV. Maybe it should be all persons with HIV. Maybe it should be individuals with a CD4 count less than 350, not necessarily 200. And they said, okay, why don't you please show me if these breakthroughs are severe? So we'll get to that next. But before we go there, limitations. First of all, we are disproportionately male in this population, and we have individuals without access to care. Of course, they're not going to be showing up in these healthcare systems EHRs. We have individuals who are engaging in HIV care and may have different health-seeking behaviors, including regular testing. I have some master's students digging into both testing as well as vaccination uptake. In our data, people with HIV are at a higher risk for severe COVID-19 illness compared to people without, and the higher detection of breakthroughs is what we observe in people with HIV, but we also observe people with HIV a lot more than we observe people without HIV. We did not describe the severity of illness in here. We're getting to that next. And our matching schema was not consistent in the VAX, but when we removed them, we did not see qualitative difference in our findings. Of course, findings may not hold when SARS-CoV-2 throws us the curveball of new variants. So we did hear our friends at the CDC when they said, so they have breakthroughs. Everybody has breakthroughs. What happens during that breakthrough? Are people with HIV having a greater risk of hospitalization or more severe outcomes when they have breakthroughs? So we said, okay, we'll go study that now. So hospitalization within 28 days of breakthrough was how we defined severe breakthrough. We had 2 ID physicians, Raynell Lang, who's a postdoc, with me, and Kelly Gibo. They looked through all of the discharge diagnoses for individuals who are hospitalized with COVID-19 within 28 days of a COVID-19 signal using our definition of breakthrough. And they excluded hospitalizations that were unlikely due to COVID, right? We're trying to remove those first. We did have one cohort who only had 1 diagnosis available, could not rank more than that. And so if COVID-19 was not the first ranked discharge diagnosis and there was more than 1 other discharge diagnosis suggestive of COVID-19, that individual was classified as being hospitalized for COVID-19. I'm not a fan of parsing for hospitalization for versus with, but when we're talking about severity of illness, it's absolutely essential to do so. So we did also have some secondary outcomes we wanted to look at: mechanical ventilation with ICD-10, not 19, but ICD-10 procedure codes and CPT codes, ECMO, as well as death. We added comorbidities for this analysis because we know how important they are, measured using ICD-10 codes. We looked for obesity, type 2 diabetes, hypertension, end-stage renal disease, and then other immune suppressive conditions, including organ or tissue transplant, RA, lupus, cancer, and pregnancy. So again, our study entry here, it's slightly changed compared to our first study. In our first study, it was the date fully vaccinated. In this study, we're going to start from the date that we observe your breakthrough, and we'll follow you to see if you do have severe breakthrough illness, which is hospitalization or outcome, death, disenrollment, December 31st, 2021, or 28 days after follow-up, because again, that's the time point that we're looking from the date of breakthrough that we would consider you having hospitalization and meeting that definition of severe breakthrough. We did estimate incidence rate, cumulative incidence. For this approach, we used discrete time to event analysis with log models. So what we see here is that we did observe 170 hospitalizations in people without HIV and 80 in people with HIV. 16 individuals without HIV had mechanical ventilation and 8 with HIV. We have been very suspect of our ability to capture mechanical ventilation. We think that's rather low. And so we tend to go back and start pushing on that, which we did for a while, and just came to the conclusion that this was not something that was as easily extractable as we thought it might be. And then we did observe some deaths among those who had a COVID-19 diagnosis within the 28 days of that. Now it's important to note here that we're not matched at the time of breakthrough. We're matched when they were fully vaccinated, but still we see very similar populations in terms of our demographic characteristics of age, sex, ethnicity, and race, and the month of the breakthrough by HIV status, which are our 2 columns, without and with HIV on the left and the right. We also see that the uptake of vaccine looks pretty similar in people with and without HIV, and we are accounting for additional doses after primary series with Pfizer, with Moderna, or with J&J, and we see overall, again, a similar rate of COVID prior to fully vaccinated. What's important to note here is that in people without HIV, we see a greater proportion who are obese, a greater proportion with diabetes, a greater proportion with hypertension, and a similar proportion with end-stage renal disease. I think it's important to remember when we're studying people without HIV, and particularly as a side note, as we study people with long COVID, that people have been very unwell during the COVID pandemic. They've delayed care. And we need to take that into account as well, that it's not all COVID, but it's a lot of downstream effects of COVID in terms of people's other chronic conditions. Also important to note here that the CD4 count at ART initiation among people with HIV who had a breakthrough was just under 400. And at the time fully vaccinated, it was over 600. 10% were unsuppressed at fully vaccinated. So this is the rate of hospitalization by HIV status. So you'll notice it's not as volatile as what we saw with the waves following the breakthrough following the waves in our first study. But overall, we do see a pretty high rate of hospitalization among those individuals who experience a breakthrough infection. So 130 out of 100 person years, and people with HIV, it was 117, and people without HIV, it was 170, remembering that our people without HIV do have a higher risk of comorbidity. And when we look at the risk, we do see that people without HIV had a higher risk of hospitalization by HIV status. And we also see that a lot of this risk and these hospitalizations are really happening within the first week or two of the diagnosis of COVID. So overall, it was about 7% who had a breakthrough ended up in the hospital within 28 days. In people with HIV, it was under that. And people without HIV, it was slightly over that. The risk difference was not statistically significant, and it was less than 1%. In people with HIV, we do see those who had a CD4 count less than 350 had a higher cumulative incidence of hospitalization. So that's the blue line on the top, and they're weighing in at almost 15% of persons who experienced a breakthrough, compared to individuals who are at the very bottom. Those were our people with HIV with a CD4 count greater than or equal to 350. And then our people without HIV, it was about a 7% cumulative incidence of hospitalization in the first 28 days after breakthrough. Oops. And then we also wanted to look by viral load. And here we do see individuals with unsuppressed viral load had a slightly higher risk of hospitalization in those 28 days. People without HIV, again, in the middle, and people with HIV with suppressed viral loads experiencing the lowest risk of hospitalization following breakthrough. It's important to note that these confidence intervals overlap. This is not statistically significant. We did look by vaccine type again, just to make sure, and we don't see differences by vaccine type when we're comparing people with and without HIV having a severe breakthrough, i.e. hospitalization after experiencing a breakthrough. What we did here was we stratified and we started to say, okay, does this additional dose really help reduce the risk of severe breakthrough, meaning hospitalization? And here we do see that green line at the top. Those are people without HIV who just have a primary series. And so they're experiencing the highest risk of hospitalization at 7.7%. And just under them are people with HIV and only a primary series, right, at 7.5%. The purple line are people without HIV who did receive an additional dose at 4.7%. And then the dotted pink line are people with HIV who received an additional dose at 2.5%. So overall, we decided that these results were probably most important stratified by CD4 count. And so we do see that individuals who have a CD4 count less than 350 had about a 60% increase in your risk of severe breakthrough if you were to experience a breakthrough, as compared to people without HIV who also experienced a breakthrough. There was no difference once adjusted for individuals who had a CD4 count greater than 350 compared to those without HIV. A few other things just to point out. So this is what, these are risk factors for people without HIV. I apologize. That's correct. People without HIV here, we can see that they do have an increased risk of severe breakthrough with hospitalization. With increasing age, that face validity all looks the same. We do see this increased risk with hypertension and with end-stage renal disease. We also see an increased risk in those who also have organ or tissue transplantation. In people with HIV, we also see the increase of hospitalization after breakthrough with increasing age. And we do see these increases among those who have end-stage renal disease, hypertension, et cetera. They are much more attenuated. These are much smaller numbers under here. And then, of course, we do see this dose response at the very bottom with CD4 count. So the lower the CD4 count, the greater the risk of hospitalization following a breakthrough. For our secondary outcomes, the left is death, the center is mechanical ventilation. The right is oxygen. We did not capture enough ECMO cases to put them into this very simple bar plot that looks at just the proportion of individuals that would have these outcomes. There are 3 bars within each of these outcomes. The far right is people with HIV with a low CD4 count, 350 or less. The center, people with HIV with a CD4 count greater than 350. And then on the right are people without HIV. And so you can see overall, these are pretty overlapping confidence intervals. These are secondary outcomes. There are not very many of them. We also have an infographic for this when the paper comes out for JAMA Open Network next week that we covered in the first half of the talk. We will also send around some social media and other things with this important follow-up that does suggest people with HIV who have a lower CD4 count of 350 or less are at an increased risk for hospitalization following breakthrough as compared to people without HIV. So, to conclude again, if you experience a breakthrough with HIV or without HIV, hospitalizations are rare. So again, You can't stress the message enough. Vaccinations work. People with HIV did have a similar risk of breakthrough compared to people without HIV. But once you start to break that group of people with HIV down into lower versus higher CD4 count with a cutoff of 350, not 200, you start to see the increased risk at 350. So yes, we send this back to our CDC colleagues and say, we think that when you are talking about immune suppressed people in your category of moderate or severe immune suppression, and we're trying to include HIV infected individuals in that group, it shouldn't be a CD4 count of 200, but rather of 350 as the cutoff. So what that would do is then individuals with a CD4 count of 350 would go into this additional category down here below, changing this piece that's highlighted here in red. So there are limitations to the second part of our study here too. Again, we're disproportionately men. That's the same as before. Again, we are looking at individuals with access to healthcare. That's the same as the first study. Mechanical ventilation and death may be under ascertained. We have serious concerns about that. We're thinking about the value of putting any of that information out there because truthfully, I'm not even sure exactly how under ascertained we are there. And so that's just very dangerous to do. Discharge diagnosis ranking was not consistent in one cohort, but when we remove that cohort in a subgroup analysis, we do not see qualitative differences in our findings. The schema situation and the matching on fully vaccinated doesn't apply as much here, but we also know from the first study, it doesn't mean very much in terms of impacting the results. And again, findings may not hold with new variants. So we do have some additional investigations going on in this work where we are going to look at patterns of both testing and boosters and do the combinations of primary series type, booster type, and infection-induced immunity have different associations with the risk of breakthrough. And are there any differences between risk of hospitalization after breakthrough by sex at birth among people with HIV? We're starting to see some signals there when we do some interactions. And of course, I welcome all of your thoughts on additional work that we could do with these data. So the CIVETS has been a wildly productive group. It's been a fun ride. It's been incredibly exhausting as well. We officially disbanded on March 31st, but keep in touch to finish pushing our papers out. So with that, I will open it up for questions.
Well, thank you so much. That was amazing. I'm just going to get the ball rolling because I've got like a whole list. So I was wondering for the studies in the first part, what was your definition of viral suppression? Was that when you were looking at vaccine response stratified? And from the perspective of, I know that I think I saw Andrea Cox and Liz Thompson, so people in a vaccine efficacy interest group. And to me, it's always been sort of an open question, and for at least some vaccines, they work better when viral suppression is achieved, right? And it's independent of CD4 count. And it was just notable to me that the protectiveness of the vaccine seemed independent of viral load, but I was wondering if the suppression cutoff was maybe too low, or it's just that it's such a highly suppressed cohort.
I think it's a highly suppressed cohort.
Okay.
I think that's where we're not seeing the difference. We used a suppression level of 50 copies, less than 50 copies. And that was within the window of January 1st, 2020, the date fully vaccinated. So if somebody was fully vaccinated on the 29th of June, we're looking for the measurement of HIV RNA closest to that date fully vaccinated. That's the one we'd pull.
Got it. Because I guess I had a couple of patients who I had, had viral loads of like 60 to 80,000, and they were starting therapy. I know them, they will probably suppress in 2 weeks. So I delayed vaccination for those people for 2 weeks because of the assumption that the vaccine would work better without 80,000 copies of virus. And so I guess this doesn't exactly answer that question, but
yeah, I would be careful with trying to infer anything from these data with that because it was such a highly suppressed population. I think your intuition on that is spot on because you do want to get, that immune response as high as you can for the SARS-CoV-2 vaccine. I think it's important to just remember too that, we are vaccinating still with the ancestral strain. Right. So that's another kind of point of all of this until Moderna's B2 comes out. We're working with that older. It's not older. It's only 2 years, but it's the older.
I thought I would just highlight that, a bunch of my patients got J&J and then a follow-up mRNA because they were hospitalized at some point. So it's nice to see that that regimen performed well in your data. I think it's applicable to plenty of Bartlett patients. But then my next question, and people should also just raise their hands. I don't mean to monopolize. I'm just so excited. The hybrid immunity question. So there's a lot of talk about this. And I just noticed that, and again, it's so hard to untangle the exposure versus the efficacy questions. But it looked like hybrid immunity was not more protective, right? It was like prior COVID infection was associated with an increased risk of breakthrough, correct?
That's right. So it's potentially signaling, oh my, like these are people who are high risk. And, that effect was driven by the Veterans Aging Cohort study.
Okay.
And, so that is a different population all in and of itself. It tends to be higher proportion Black, higher proportion lower socioeconomic status. So individuals that we think about needing to be on the front lines a lot more, whether that's, Uber driving or whatever it might have been. I just think that signal for us was more so a signal of individuals who were and had higher risk for exposure. I think the hybrid immunity question should not be answered with data, even from Delta. I think it must be answered with data from Omicron. And our data only go through December 31st, 2021. So just the beginning of Omicron. I mean, I think the question is for right now, right? Seeing the second wave of disease, our May surge, which I was on a call on Tuesday morning, an NIAID call, and people are trying to get at this question of how under ascertained are our case counts right now? Like, what's the magnitude of that? Like, let's ballpark it, right? And there are a couple of population-based studies that are coming out with estimates that it could be anywhere from 10 to 33-fold. Yeah. 10 to 33-fold.
Yeah.
So if that's true in the state of Maryland, who reported 2,625 new cases yesterday. If we are even tenfold under ascertainment due to all the at-home testing and people just not testing anymore, we are surging higher than what our capture numbers were with Omicron in January right now.
Yeah. No, I mean, I just got a text during this that someone who's supposed to come to work next week tested positive at home. So I mean, based on that, I mean, it seems entirely plausible.
Yeah. So I think the immunity that people are building right now, if you are fully vaccinated and boosted and you're infected with Omicron either in January or May, I would love to start to see, if we're going to ask that question about hybrid immunity, let's ask it now.
Yeah, no, I think that sounds really smart. The other thing that I just couldn't resist was that looks like a 2.88 odds ratio risk for females with HIV to be hospitalized. And I was wondering if that's just because, well, first of all, because females with HIV in the United States tend to represent a lot of disenfranchisement on multiple social determinants of health levels, in addition to other things, but also that they just were such a minority of the study population. Mm-hmm. But I actually also wanted to ask why, because these are like, I mean, women are 25% of the people with HIV in the US, right? So why are they so underrepresented in these cohorts? Setting aside the vax, which has...
Yeah, so when we take the vax out, they're not.
Okay.
Right? Because the vax is just like this gorilla, this ginormous elephant that comes into the data. And we love it because it's they are still the biological difference by sex at birth, those are real. Whether or not someone who is a person born male in the vax is different than a person born male enrolled in KP. I think there's, those biological differences are not nearly what anyone would want to argue. But I think this question about women, so we are digging into this because even though absolutely like our study population overall with the vax included is predominantly men, but among our women, it's still over 2,000 women that we see. So we are working to dig in there. I have a student who's looking at sex differences right now, both in breakthrough and in severity.
Yeah, no, that'll be really interesting to see because, I mean, the signals about increased severity in males have been fairly consistent with the exception of in the older age groups, but we know that inflammation is different in HIV. So whether those two things intersect differently is really an open question.
That's right. And then I think, you can't, it's a hard thing to kind of noodle through your brain, then how unfavorable social determinants of health are also playing a role in this context and in this time when, women, we also know that during this time, women were more likely to be home with children and more likely to do all these different things that both, potentially could protect them from exposure, but potentially not once those kids start going back to school. And then the added stress of all of this and women dropping out of the workforce during this time, which I have to be honest, I considered this week when I was quarantined with my 3 children. It doesn't end. So there's a lot to tease out.
So I'll stop monopolizing. Are there other people who'd like to either put a question in the chat or raise your hand or unmute? I saw a bunch of people clapping while I was with their little hands while I was peppering you with questions. So, but please, other people, feel free to unmute. Still learning the exact amount of Zoom pause that's required. So I'll just finish with the last. I mean, this was fantastic, and thank you so much for presenting all this data. And I should remind everybody, she did present this to us early. It is embargoed, so don't tell anybody about it in a public way until December, not December, June 7th.
Yeah.
Right. But with the 4th dose question, I mean, I think there's like sort of 2 layers there. One of them is immunologically, or is priming still back to the old strain the right plan? And I think the point you just made a moment ago about whether we're under ascertaining right now and whether we should be worried about a fall surge versus addressing infection risk at this very moment, I think remains an open question. But I guess what I would ask you is how would you approach that? Like what kinds of like you can't answer it, but what study would you want?
So I think that the thing that we have to really be careful of what are the risks, right? What are the risks to doing that 4th dose? And some of them are, okay, we can follow and watch. And, the post marketing trials are supposed to be watching for a lot of this, right? Because that's where we're getting this information from. But I also think there are other risks that you can't fully quantify. And that is what this scenario may look like if Moderna is able to push out a B2 change up in their booster for the summer, and would waiting for that then help to confer greater protection for the fall. And everybody's kind of keeping an eye on B4 and B5, which I'm hearing preliminary studies are suggesting, in vitro, that there's some pretty solid immune escape there, and how that will play out in terms of disease severity has still yet to be seen. And I think, the other thing that makes me more nervous than ever is that we are not as in lockstep 2 months behind the UK and other European countries as we were before. We saw this spring, the European countries had a different experience than what we did immediately following their first Omicron surge. So I'm not sure we can count on that. So for me, I think the harder question is something we can't fully quantify yet, which is if Moderna puts forward a B2 booster this summer, is that going to be the best protection? Or do we just say, yikes, we are in a surge right now. We should be boosting right now with the ancestral strains as a 4th dose. I don't know how to answer that question. I wish Moderna would put out some more information, a better timeline on this. And I think, the answer is also highly variable based on what we continue to watch and see what happens in South Africa with B4 and B5.
Well, great. Thank you so much for answering an unanswerable question. If there's just more thanks and applause in the chat, but if anyone else, this is your moment. But in the absence of anyone unmuting, thank you so much for joining us. This was really fantastic. And have a wonderful holiday weekend. Hopefully get out of quarantine. And thanks to everybody for joining.
Thanks for having me. Thanks for all your hard work on the front lines, everyone. Bye.